There are three hormones produced by the adrenal glands. They are the salt, sugar, and sex hormones in the female. Now, in the male, only two hormones, which are the salt and sugar hormones. Salt hormone, as you know, is the aldosterone, and the sugar hormone is cortisol. Okay. By the way, this is not the entire adrenal gland disorders we're talking about today. So we're only talking about the adrenal cortex. Okay, the adrenal medulla, of course, produces epinephrine or epinephrine. So this is only about the adrenal cortex problems. Okay, so this is anatomy review. So I'll let you read that. Okay, and the effects of glucocorticoids, which is cortisol. So this is the stress hormone. Yeah. 1474. Now, cortisol is always released in response to stress. Stress can be an exam, it could be getting married, getting divorced, having a child, losing a child, right? So anything stressful, okay? Cortisol levels are increased, and what are the effects on this on the body?
Increase.
Let's get this out of the way, because right later when I discuss the disorder, I don't have to repeat what they do, because now the disorders will just say they have a deficiency or an overproduction of the hormone. Okay, so what's the effect of glucocorticoids or cortisol? Okay, so it increases blood pressure, okay, because it causes fluid retention. It increases blood glucose, okay. It causes, therefore, the breakdown of glycogen from your liver, okay. And of course, once this releases so much sugar, then excess sugar will be turned into fat. So this will, therefore, cortisol makes you fat, okay. And then third, because it's a stress hormone, what happens to the immune system or inflammatory response? Okay, so those are the major effects of cortisol. Okay, so you can just imagine what happens if you have too much of it or not enough cortisol. Any question? Let's go to the next hormone. Mineralocorticoids is the salt hormone. This is referring to aldosterone. What are the effects of aldosterone? Okay, promote sodium and water reabsorption in the kidneys and the GI tract. So the effects would, of course, be when you retain sodium, what will happen to potassium? Okay, so sodium potassium pump, yeah? So you retain sodium, you lose potassium. And what happens to blood pressure also? Rises. What happens to blood volume? Okay. And finally, the sex hormones. Now, the sex hormones obviously are not life-threatening when you have too much or not enough of it. However, do they have a psychological impact on the patient?
Yes.
Meaning, if the woman now looks like a man or a man looks like a woman, right? So that becomes a problem, yeah? Or although, again, that's not life-threatening per se, although the patient may think about suicide, but that's not really caused by the disorder really directly, yeah. So it's more like a reaction to the sex hormone changes. Okay. Okay, this one is a short topic. What is pheochromocytoma? It's a tumor. It's a rare tumor that grows on the adrenal medulla. What are the hormones again produced by the adrenal medulla? Epinephrine and norepinephrine. Okay. So if you have a tumor there that grows in the medulla, what will happen to epinephrine and norepinephrine? It actually increases. Okay. So therefore, if you have high levels of epinephrine or norepinephrine, what will you look like? You look like a chicken. Okay. You look like this. Always hyperactive. So your blood pressure is so high, your heart rate so high. Right? What can go wrong with that? You could have a stroke, you could have a heart attack, right? So here, all the manifestations are related to high blood pressure. That's the main problem with these patients. Blood pressure systolic will be over 200. Diastolic will be over 110. Okay? Constantly high. So what medications do you foresee as going to be prescribed here? A lot of blood pressure medications. Okay, we'll get to the management shortly. So patient, again, manifestation is all related to high blood pressure. So what are manifestations of high blood pressure? Okay, you got them here. Headache, diaphoresis, palpitations. We also got tremors, flushing, right? And there's a sidebar effect here. There also be hyperglycemia because when you have epinephrine, will you also have glucagon release? Yes, so that will lead to hyperglycemia as well. Okay, so again, these are more manifestations, all related to high blood pressure. Okay, and of course, because of the tachycardia, the severe tachycardia, the patient will also have a feeling of impending doom. Okay, and the consequences, of course, of high blood pressure, we mentioned stroke, heart attack, it will also be AKI. Okay, and if not treated, this patient will go into CKD. Now, the tumor itself is actually big. So when you palpate this patient's abdomen, there is a palpable tumor here. The tumor is that big that it can be palpable. Whatever you do is do not palpate the tumor, because what will happen? You will have a sudden release of your epinephrine and it may cause a hemorrhagic stroke. Ooh. So do not poke it. Okay, so when you see, I see it. Okay, what is this? Okay, don't do that. Okay, because the patient may have a stroke right there when you do that.
You said abdomen, is it?
It's in the abdomen because the kidneys are on the back, but then because of the rib cage, you can't really feel the tumor behind. You feel the tumor anteriorly. So here are the manifestations, 5 H's. And of course, we look at the blood serum levels will indicate really high catecholamine levels. Let's go to management. Surgery is the only cure. We have to remove the adrenal gland because the tumor is that big. Cannot you really save the adrenal gland when it grows? Because it's not like on top, okay? It's growing inside the adrenal gland. So we have to remove the adrenal gland. Now, if the patient is not a candidate yet, meaning they're not stable for surgery, then we treat them first with medications. Here are a long list of medications that will both do decrease preload, decrease afterload. So we're talking vasodilators as well as diuretics. Okay, and of course we need to control sodium. Okay. So once stable, then the patient will undergo surgery. Now, how many adrenal glands will depend. How many tumors do you have? Did the pheochromocytoma grow in one, or did they grow in both adrenal glands? Now, the consequences will be depending on how many adrenal glands were removed. So if it's one adrenal gland, then the patient still has one more, correct? So, and what will happen to the hormones that used to be produced by that adrenal gland? It's gone, right? So now you only have one gland remaining. So do we need to supplement that? Yes. So for a while, for maybe a few months to up to 2 years, depending on the patient's level, because we don't know when the remaining gland can compensate for the loss of the other one, right? So until then, we keep monitoring the patient's hormone levels and we will have to give them supplemental hormones in the form of Solucortef. The benefit of Solucortef is it has both a glucocorticoid and mineralocorticoid effects. Okay, so one drug, two effects, has both the benefits of sugar and salt hormones, depending on the dose. So patient will be on that for until again the hormone levels stabilize. Okay, and then we can stop the supplement. What if it's both adrenal glands that are gone? Then they'll be on lifelong hormone replacement. Okay, we'll talk about those later and their what?
The name of the mutation.
Soliocortef, hydrocortisone.
That's a steroid.
Yes, we're talking about hormones. Yeah, steroids, glucocorticoids, and mineralocorticoids. Okay. Also, patient may have a hypertensive crisis. You still remember management of a hypertensive crisis? What was the first action? That will make it worse.
Beta blocker.
No, what was the first intervention?
Oh, hyper.
This is from MedSearch 1. So what was the first intervention? Wasn't even a drug.
What?
What was the first intervention?
Oh, food that change your.
You also,
lifestyle.
no,
What?
you also talked about this, remember eclampsia, pre-eclampsia?
Ah,
What was the first intervention? It's the same. Because in eclampsia, pre-eclampsia, we're dealing with the same high blood pressure.
seizure precaution? Bed.
Place the patient in a sitting position. That was the first intervention. And then monitor neuro symptoms, okay? Right, so seizure and also stroke. Okay, so that's first, what was the first action again? Place the patient in a sitting position. So what, how do you describe a sitting position? How many, what are the terms we use? Semi or high or Fowler's?
Not high.
Fowler's or high Fowler's, that's a sitting position. Semi Fowler's is a reclining position. Okay, we need to sit them up.
So 45.
No, not 45. 60 to 90.
Okay.
Okay, that's Fowler's and high Fowler's.
Okay.
And of course, followed by you monitor neurologic status and then prepare to administer medications. So in that order. Do we leave the patient?
No.
No.
Powders.
Okay, I already mentioned this earlier. Corticoid replacement is required if the patient loses both adrenal glands. Okay, so and then if only one gland was lost, then short-term hormone replacement. Okay. That's about it. Okay, let's proceed with the next one. Okay, so this is the second to the last. After this, we'll talk about Cushing's. Adrenocortical insufficiency, also called adrenal insufficiency. Now, Addison's disease is actually only for primary adrenal insufficiency. Okay, so don't interchange adrenal insufficiency. Don't assume, oh, that's Addison's. No, Addison's is primary adrenal insufficiency. So what's the problem with Addison's disease? Whether it's Addison's disease, adrenal insufficiency, adrenal crisis, all these patients have low salt and sugar hormones, meaning their cortisol and their aldosterone are both low. I repeat, whichever type of adrenal insufficiency the patient has, whether it's Addison's disease or let's say adrenal insufficiency, the patient has low aldosterone and low cortisol levels. Okay, the sugar and salt hormones are low. And if it's a female, then that means the sex hormones are also low. All right. Okay, again, this doesn't affect males. Because where are the sex hormones from the male? From the testicles. Okay, it's not in the adrenal gland. Okay, so the problem in Addison's disease, there's a problem with the hypothalamus. Now, what's the hypothalamus role here? Okay, so the pituitary gland is the master gland, correct? which controls the adrenal gland. Yeah. So the problem here is there's a miscommunication here between these three organs. The hypothalamus, of course, is the one tracking the hormone levels in the blood, and then it tells the pituitary gland its findings, and then the pituitary gland will tell the adrenal gland what to do. All right. So that's how it works. Addison's disease is rare. Okay. Manifestation. So what will somebody with low salt and low sugar hormones look like? So what is their blood pressure?
Low.
Hypotension. What is their sugar levels? Low. What is their potassium levels? High. Right, because they have low sodium, low blood pressure, so potassium levels will be high. Okay. All right. So keep those three problems in mind. Now, let's say it's Addison's disease. So how do they react to stressful events, therefore?
Okay.
Oh, like surgery, an infection, a breakup.
They're very passive.
It could actually kill them. Okay, all right. So any event, let's say most common, we call that condition an Addisonian crisis, okay, which is life-threatening. What is their sugar levels again?
Oh, so it gets even lower.
Low. So in Addisonian crisis, it's severely low. What is their blood pressure again?
Low.
In Addisonian crisis, they will go into shock. What is their potassium levels again?
High. Also gets
In
higher.
Addisonian crisis, they are in severe hyperkalemia. Okay,
Mhm.
so what triggers an Addisonian crisis? Again, I repeat, any stressful event. The events I mentioned earlier, but most common for these patients is they got sick. They got the flu, they got pneumonia, they got COVID. They went into Addisonian crisis. Could they die? Yes. Another cause of Addisonian crisis is, you remember people, you were taught something in pharmacology about steroids. If I'm taking steroids for a long time, how should I stop?
Take it off gradually.
What was the rationale for gradually weaning you off steroids? Why can't I stop cold turkey? Why do I have to taper it down slowly? This is the reason. You could die from Addisonian crisis or adrenal crisis, okay? So that's another cause. So either the Addison's disease patient experienced something, a stressful event, or someone taking steroids for a long period of time suddenly stopped. Why did they stop? We don't know. They could have gotten sick. Maybe they were mugged, okay? They went unconscious. Now, how can they take their steroids? They're unconscious, okay? Or they got sick, all right? So these are the events that lead to Addisonian crisis. Look at the consequences, okay? Here. Slight overexertion, exposure to cold, acute infection, or decrease in salt intake can lead to circulatory collapse, shock, and death, okay, if untreated. All right. Any questions so far? All right. So with the management, so it's actually pretty simple. If you have Addison's disease or adrenal insufficiency, what's the management? They have low salt and sugar hormones. So what do we give them? The hormone replacement. For how long? For life. Okay. So they have to take it every day. Then we'll look at the teaching, because can they get sick from taking hormones? Yes. So therefore, we have to teach them what to do when they get sick and cannot take them by mouth. Because what will happen if they suddenly stop because they can't take it? They're too sick. They'll go into a crisis. All right. Okay. Now, it's a different thing now if it's a crisis, because now can we just give the hormone and expect them to be okay? No, because they were doing that before they went into a crisis, correct? They've been doing that. They've been taking the hormones. However, they're in a crisis. So do you think these patients are awake?
No.
Are they conscious? No. In an Addisonian crisis, these patients are unconscious, unresponsive. Okay. So is it an emergency? Okay. All right, let's look at the management now. Of course, we have to stabilize the patient. So our ABC, of course, will be the. By the way, if I ask you which of the three will kill the patient first, shock, hypoglycemia, or the hyperkalemia, which one will kill the patient first?
No, the hyperkalemia.
Actually, all three can kill the patient
So no hyper-
independently, right?
It's just at risk.
Each one doesn't need the other to kill the patient. I mean, can you die from hypoglycemia?
Very much.
Can you die from shock?
Yes.
Can you die from hyperkalemia? Yes, each one doesn't need the other. So do we have a choice as to which one we treat first?
No.
Actually, no. So we have to treat all three together. So is this patient on a regular med-surg floor?
No.
Mm-mm. This patient is an ICU patient. If they're in crisis, all right? Are we clear about this? Because there is different, again, if it's Addison's disease, they're fine, okay, as long as they take their hormones. In a crisis, however,
Mhm.
are they going to die?
Yeah.
Yes, so they're in ICU. So this is what we do. Immediate treatment. Okay, so again, these are all done simultaneously. Okay, there's no choice. I'll do the fluids first. I'll do the insulin with dextrose. You still remember the interventions for hyperkalemia? The calcium gluconate, the sodium bicarbonate, the insulin with dextrose, the diuretics, the patiromer or SPS, sodium polystyrene sulfonate. Okay, so all those are in play here. So we give, of course, about shock. So we give, what type of shock is this? Hypovolemic. Okay, this is hypovolemic shock. Okay, because of the low aldosterone. Okay, so we're gonna give fluids and steroids. Now the steroid here will be hydrocortisone. Look at how many steroid doses we're giving here. So hydrocortisone will be given. One will be IV, meaning IV push, and then lots of fluids. The beauty about D5 normal is it not only increases blood volume, plus there's also dextrose in there, so it will also raise the sugar. Okay. Then if doesn't respond, I mean, you know about vasopressors, right? Okay, so we already talked about that under shock. Now, what about the glucose? So again, the dextrose probably will not be enough, so you may need to administer either glucagon or D50. Okay, push. Okay, then meanwhile for the hyperkalemia, I already mentioned the interventions. If you forgot already, please go back to chapter 10 for 12 for the hyperkalemia under fluid and electrolytes, right? But it'll be still on the exam, okay, even if it's not in this chapter. So here the chapter does it paragraph by paragraph. Fluids, and then yeah, it's already mentioned. And okay, here's our teaching now. Because if they're taking hormones, could they potentially not take enough? Let's say they're in a stressful, so let's say I'm on 50 milligrams twice a day of hydrocortisone. And it's exam week. Next week is my first exam. So are my hormone needs and my hormone intake the same this week versus next week? So what do I do? Could I potentially not get enough? Okay, so what do I do? Can I do it? Okay, so I have to call my doctor. Hey, I have an exam coming up. What would be your recommendation, doctor? So they'll give you instructions on how much additional hormones to take. Do not tell the patient to take it on their own. They don't tell them, okay, double up when you're, let's say, with a new guy, okay, going on a new date, or an additional date. You have a second guy, okay, double it. Oh, I have a third guy, triple it. Okay. No, you tell the patient to consult their doctor. Okay, so the patient will tell the doctor, hey, I have a third boyfriend this week. What do I do? Okay. No, you have a problem with that? Yeah, I know some women with that. I was one of those boyfriends.
Number 6?
No, I was number 3.
That's good, you're up under us.
Yeah. And we know each other. Okay?
Top 3.
Well, the other one was my friend, so no problem. But the third guy we didn't like.
Do y'all still saw the girl even after you? You know what? You get what you need to get.
Yeah, we can handle it. Okay, here. Okay, so wear a medic alert. Okay, make sure people are aware that your condition, adrenal insufficiency or Addison's disease, whatever. Then avoid strenuous activity. Okay, for obvious reasons that will increase your metabolic needs and therefore your hormone needs. So that includes management of how to manage stress more effectively. Okay, if you get sick or you're about to undergo a procedure, basically stressful events, okay? Basically stressful events. Notify your physician. What's the purpose again?
To prevent.
Because what will the doctor tell you to do? Okay, increase your hormone doses. Okay. Increase fluid intake and salt intake. Okay, especially in the summer or if you're losing it. Yeah, let's say it's so hot, you're perspiring more than usual. What's the diet? High carb, high protein with adequate sodium intake. And then again, teach them about the signs of adrenal crisis. What are those 3 signs again? Hypotension, hyperkalemia, and hyperglycemia. Now, of course, that won't appear like that on the exam question. Okay, so your select all apply question. Will I put those 3 or manifestations of those 3? Okay.
Oh.
Because what's your teaching? Are you gonna teach the patient? Watch for hypoglycemia. Okay. Oh, patient say, what is that? Okay, so they don't know what the hypoglycemia symptoms are or hyperkalemia, right? So they don't know about muscle weakness or palpitations. Would they know about that? Oh, I didn't know this was hyperkalemia, right? Make sense? So again, so same thing. So if I expect you to teach the patient, then that's how I'll test it. Okay, the emergency kit. What is this emergency kit? What do you think is in it?
Glucagon.
This is if it's an emergency, is it oral or
Glucagon.
injection? Okay, this will be an injection. Okay, so this will be either pre-filled syringe of hydrocortisone or could be a vial with depends okay what kit they have. Of course, the more expensive one would be pre-filled, cheaper one would be a vial and a syringe. Yes.
So they'll do them.
Usually we teach the patient and a caregiver. Because if they're in crisis, I mean, are they even aware that they're in no, they're already unconscious. So a family member will be taught. Okay. And no emergency numbers, who can they call? Or if you're not sure, call 911. Go to the ER. And that's it. And of course, what do we teach them about the steroid dose again? Okay, they cannot stop it suddenly. What if again they're too sick to take it? Okay, call either the emergency kit, get an injection, or take them to the hospital. Okay, and then tell them the consequences if they suddenly stop. Okay. Any questions on Addison's disease? Okay, last topic, Cushing's. Now, Cushing's, there's 2 forms of Cushing's here. We have Cushing's disease and there's also Cushing's syndrome. Now, the difference is Cushing's syndrome is what happens if that Addison's disease patient we were talking about a few seconds ago takes too much of the hormone. Then they will have the other problems. Now they have too high cortisol, too high aldosterone. So now the problem will be opposite, exactly opposite. So what happens to their blood pressure? Really high. What happens to blood volume? Okay, that's why blood pressure is high. what will happen to their potassium level? Low, and because sodium is so high. And then sugar will be very high. So high salt, sugar, and sex hormones. Okay. Again, this will only affect, if as far as the sex hormones, this will only affect the female patient. Okay. Now, Cushing's disease is different because in Cushing's syndrome, where did the steroid come from?
Oh,
From the Addison.
You were taking it. The patient was taking it by mouth or by injection. Okay. Cushing's disease, same exact manifestations, but this is caused by usually a tumor, usually a pituitary tumor. Okay, a tumor that is causing the adrenal glands to produce more salt and sugar hormones. Okay, so that's the difference between the two. So where did the steroids come from in Cushing's disease? Where did it come from? Endogenous. The patient's own adrenal glands produced it because again, why?
Because of it.
There's a tumor in the pituitary. Now the tumor can also be from the adrenal gland itself. Okay, remember pheochromocytoma? Okay, so it's not pheochromocytoma, but another, we call it an adrenal adenoma. Okay, so an adrenal adenoma or a pituitary adenoma. Okay, so tumors, but tumor could be from the pituitary gland or in the adrenal gland itself. Okay, you know the difference between the two. Okay, so therefore, are they treated the same way? No, obviously not. Cushing syndrome caused by too much hormone medication. What's the cause of Cushing's disease? A tumor. Where are the tumors? Pituitary or in the adrenal gland. So we can't treat them the same way. Because let's say, without looking at the textbook, how do we treat Cushing syndrome?
You remove what the extra.
Can we stop the hormone?
No, decrease it.
We can decrease the dose because the patient needs it, obviously, right? But
Not the one.
yeah, they just took a little too much. So meaning, did they need the steroids? Yes,
Yeah.
that's why they were taking it. Okay, we just need to adjust the dose that way they don't have the Cushing syndrome. Now let's look at the so that you have a idea about because we talked about the manifestations, yeah. So the high blood pressure, high sugar, the water retention, the edema, the hypokalemia, right? But look at the manifestations. We have a picture here, actually. Okay. That is a woman. That is a woman. This is a woman. Okay. So this is what you look like if you have Cushing syndrome. Okay. So just look at what we can see here. So we have facial edema. We have buffalo hump. If this patient was turning around, there's a big pad of fat on the back of the head, and there'll be edema all over. There'll be abdominal obesity. Okay, so we call this the moon face. Okay, just like mine. Okay, moon face. There's facial hair. Again, this is a woman. Okay, this is not a guy. So let's look at the whole picture here and then just imagine. You know what? Let's look at online. So let's look at Cushing's syndrome so that you can appreciate the whole body manifestations. I forgot we have no internet. Never mind. Okay, so let's just look at this. But anyway, look at someone really. I mean, I don't want to say they're fat because the fat is in certain areas of the body here, back of the neck. Of course, arms here will have fat, the hips, but then most of it will be in the abdomen. Okay, so the abdomen here will be very pendulous. Now, the problem is that's why you see under the skin, and of course, the fluid retention here will cause heart failure and hypertension. You know that. And because of the high female hormones, there will be acne. So they'll be like teenagers again. Okay, they'll have skin breakouts. And the thinning of the skin is actually called, and the stria, no, the stretch marks, because the abdominal obesity did not occur like over months. This occurred like really fast within a few weeks. So therefore, did the skin have any time to adjust? No, the skin was stretched in such a short period of time that it causes stretch marks and the thinning of the skin. So they're prone to injury actually. Plus add the edema, and there'll be some petechia here because again the skin is, there'll be microscopic bleeding here from capillaries, injured. The capillaries will break if you handle them in the wrong way. Here the accumulation of fat, because what will happen, where did this fat come from? The sugar, right? Sugar will always be turned to fat because they have too much sugar. Will the body will just store it wherever it can. So it throws it here at the back of the neck, around the abdomen, around the hips. So they're losing muscle as well, as a result of the fat deposits. So they'll lose muscle. They'll go into a negative nitrogen balance. So they look really fat, but they're actually malnourished. Okay, so their protein levels would be very low. The truncal obesity I mentioned, yeah. And there's pancreatitis, peptic ulcers also. Now, the peptic ulcer, because what happened again to your acid secretion, if you have really high stress hormone, high cortisol, it increases the stomach acids. So therefore, there can be peptic ulcer. Now, the pancreatitis here will actually contribute to the hyperglycemia, because now if you have pancreatitis, what happens to insulin production? Decreases insulin, and now you have even more higher blood sugar. And of course, your stress hormones are high, so these patients are at risk for infection, correct? And like I said, there's muscle wasting, so there will be negative nitrogen balance. Of course, there's muscle weakness also. They'll have cataracts, glaucoma, and then mood. Remember, their female hormones, sex hormones are out of whack, so they'll have very moody. Okay, they could even go psychotic. Osteoporosis, again, all because calcium absorption is affected here with high stomach acids, as well as the muscle loss will contribute to osteoporosis. And they'll have compression fractures. So in addition to skin injuries, they're also prone to pathological fractures. So safety is a concern here. All right. Now, before we go to the medication management or surgery, let's look at nursing care. So if look at all of these problems here. So do you know what your nursing care is? What do we do with vital signs? Okay, your sugar, you check it too, yeah? As far as skin, how do you protect the skin? Okay, so you have air mattress maybe, okay, and turning and positioning, and fall prevention, yeah, and bleeding preventions. What else? So a lot of support, yeah. Remember, these patients will be angry all the time, okay, moody, right? So they'll be shouting at you. And what is your natural response? You're a nurse, and then you see this woman that looks like a man shouting at you.
You want to shout back like a man?
Okay, so keep in mind, this is all manifestations of the disorder. Okay, it's not like they're like that. Okay, these are all manifestations. Okay. All right, let's go to the. I want test you on the testing because they have a bunch of tests here. They call it cortisol suppression test or dexamethasone actually suppression test, but I mean we have no role in that. Doctor does all that, so we'll skip it. So management, like we said earlier, if it's Cushing's syndrome, what is expected?
We will taper off.
Okay, taper the dose. Now, of course, when we taper the dose or decrease the dosing, tell the patient to be realistic. Okay, set realistic expectations. Don't expect them, oh, this will be, you won't look like this next week. It'll be a while, okay? Because remember, we stop the steroids? It'll be a gentle tapering. So therefore, expect the changes to be,
Over a period of time.
yeah, it'll be a while. So you're gonna look like this for a while. All right. Just make it clear in the first place. Plus, it won't be absolutely back to how you were because you need the steroids. Okay, so there will always have some degree of cushiness. I don't know how to else to call it, but it'll be better than how you are right now. Now, what if it's disease? Okay, okay, because it's caused by a tumor, so we have to remove the tumor. Okay, let's start with the pituitary adenoma. So where's the pituitary gland?
Brain.
It's in the brain. Where exactly?
Right here.
Right here, between your eyes. So behind your eyeball is the pituitary gland. How big is it? It's a pea-sized organ. Okay, so it's a pea-sized organ, so the tumor is probably about double that size or triple. So to get to it, do we need to drill here, open it, and then get it? Okay, so now the preferred approach is transsphenoidal hypophyseectomy. Hypophyseectomy is the removal of the pituitary gland. Transsphenoidal meaning they'll go through the nose. So both nostrils will be used with the instruments, then they'll remove the sphenoid bone and then get to the tumor. Now, is this brain surgery?
Yes.
Yes, this is brain surgery done through the nose. So when you're picking your nose like this, taking something out, that's actually brain surgery. Okay? So you're doing that every single day now. Yeah? And what do you do with it? Roll it to a ball or flick it on someone?
Ew, are you telling us something? No. Exposing yourself?
I'm not folding these chairs. I don't know, especially your chair.
No, you telling me.
Radiation is an option, but it's not very common. So let's talk about, okay, so hypophyseectomy is not in this chapter, so we'll go back to this. Can you remember 1480, please? Okay. What page number?
14.
Okay, so let me go to chapter 61 because that's where hypophyseectomy is, because you need to know pre and post-op responsibilities. 61 would be here. Okay, right here. So this is if the patient has a pituitary adenoma. Let's start with pre-op. Okay. So pre-op, you tell the patient what's going to happen. So you tell them, describe the procedure. Okay, so the doctor explains this also, but if again, to reinforce the teaching, you tell them what to do. Plus the doctor most likely won't be there post-op because they're not going to wait until the patient's awake. So you're there when they wake up. So when they wake up, they're going to have a packing in both nostrils, a really tight packing. So can they breathe through the nose? They'll have to breathe through their mouth for the first 2 days. Now, the dressing, of course, because you mess with the brain, will there be bleeding? Yes. So the packing will be bloody, and there'll be a mustache dressing here to absorb the excess drainage. So how do we know whether there is a CSF leak?
Clear fluid.
Well, again, the drainage will not be clear because it's bloody.
Uh,
So if there is a clear drainage, it'll be mixed with the blood. So how do we know that that drainage contains cerebrospinal fluid? With what? How do we test it?
Swab.
The same thing that you did this on.
Okay, so CSF has glucose, correct?
Ah.
The problem is blood also has glucose.
Mhm.
So if you're saying, oh, let's test it for sugar, it will always be positive because again, the drainage is bloody. So the better way to do it is you gave the answer.
Swab.
Dab it, no, not swab. Dab it with a gauze. Get a clean gauze, dab it. If there's a yellow ring around the blood, that's CSF. And we call that the halo sign. Have you
Oh,
heard? You've heard
yeah,
this before,
yeah.
eh? Okay, so that's the halo sign. So that's the only way we can tell.
Okay.
So the dextrose testing is useless because of course there's gonna be blood. I mean, there's gonna be sugar. Okay, so here are the other teachings. So we tell them, okay, our concern is because this is brain surgery, we don't want any increased intracranial pressure. So what are activities that cause increased ICP?
Coffee,
Okay,
smoking.
so what do these three? Let's just take a look at these three. There are over other activities.
Activate the vagus.
So what do they have in common? What did this patient do? What do you do before bending over, before straining, before urinating, or
Stimulate the vagus.
you took a deep breath and then what did you do?
Push. Stimulate.
You held your breath, yeah?
Yeah.
Okay, so that's the activity that we don't want to do because
What
what
you
will
do?
what will happen if you take a deep breath and hold it to push or bend over
The vagus.
or urinate
All of that.
or have
Pressure in the
sex, huh?
Increase the pressure. in the
Okay,
head.
because the intrathoracic pressure increases when you inhale and hold your breath. So what happens to venous return from the head?
It's going to slow down.
Okay. So therefore, you're not limited to this. On the exam question, I will include any other activity that causes you to
Hold your breath.
hold your breath. What are examples? Be creative.
Leaning, pushing, pulling.
Sexual
Somebody
activity.
farted. Someone farted.
Sexual activity.
Eagle up the side.
Yes, that's a lot of holding your breath. Yeah.
You hold your breath?
Yeah, because that involves a lot of pushing and pulling. That involves holding your breath.
I want to be a fly on the wall.
You're single, aren't you?
No, it was what she said, but also no. It was what she said. Don't say the same here.
All right. Remember last semester we talked about diabetes insipidus and SIADH? What was the cause of those?
They were talking about-
Brain trauma, stroke, head injury. Is this head trauma?
Mhm.
Yes, the brain surgery, although minimally invasive, is still brain trauma. So can they develop diabetes insipidus?
Yeah.
Yes, so I won't repeat that. We did finish that last semester.
Even hyperthyroidism.
Diabetes insipidus?
No,
Oh.
they removed pituitary.
Yeah, because it's related to the ACP.
In
The
hypothyroidism?
thyroid stimulating hormone, the TSH, where is it?
No, because when we discussed hyperthyroidism, it was Graves' disease.
No. Where's the TSH?
Yeah,
The
produced by
thyroid-
the pituitary gland.
Yeah, so if you remove that,
Pituitary will
could
be
you
hyper.
cause a decrease for the hormone?
Not necessarily.
So what's it?
Okay, so let's finish the post-op teaching. Now, there's also actually an incision at the roof of the mouth, a small incision, but nevertheless, we tell the patient not to brush their teeth. They're allowed to do mouth rinses. Okay, they can do oral rinse, but no brushing their teeth because you might accidentally hit this incision, okay, above the teeth. And that's it. Any question on hypovasectomy? All right, let's go back to what page again?
1480.
So let's go now to adrenalectomy again. Now with adrenalectomy, your your preparation here is well, it's not described here, but let me just discuss it. So the patient has Cushing's disease, correct? Okay, we already finished adrenalectomy, hypophyseectomy if it's a pituitary adenoma. Now let's discuss if it's a adrenal adenoma. Before the surgery, what was the patient's sugar and salt hormone levels?
Elevated.
Very high. So if it's caused by the tumor, and what do you imagine will happen during the surgery? So what will we do to the blood vessels that supplying the adrenal gland? We will clamp them, right? And then when we remove the tumor and the gland, what will happen to the production of the hormone? Did it stop slowly or did it stop suddenly? It stopped suddenly. So what could happen in this scenario?
Sudden drop off.
Which is
Addison's crisis.
Addison's crisis. Can the patient die?
Yeah.
Yes, they'll die right there on the operating room table. So how do we prevent this? Because we're taking the gland out along with the tumor, which will cause a sudden cessation of hormone production. So what do we give? We're gonna give steroids. Okay, so 2 weeks, up to 2 weeks before, we'll start it. We're gonna start giving the patient steroids. So what do you think will be the hormone production if you give the patient steroids? We're gonna maintain it. So in a way, can it also suppress endogenous hormone secretion? Yes. So that way, we give it before, and what do we do during the surgery? Do we continue the steroids? Yes. During surgery, we also continue giving steroids, infusion. And what about after the surgery? We also continue. Okay. Well, again, if it's unilateral right here, if it's one tumor, if it's unilateral adrenalectomy, how long is the hormone replacement? Okay, temporary. Okay, as there's no set time. I know the book said weeks to months, but a few days to weeks, but depends. When is the remaining gland gonna compensate? What if it's both?
Then you for life.
Okay. Now, think about it. They started with Cushing's disease, correct? Wherein their sugar and salt hormones were high. Yeah? Okay. Now, if they lost both adrenal glands, what's the treatment again? For life?
Steroids.
Steroids for life. What could they develop over time? No. What condition could they develop? Cushing's syndrome. So how are you going to explain all this to the patient? The patient will go, let me get this straight.
Up, down.
Right now, I got Cushing's disease. And you're telling me you're going to do surgery to remove the tumor in my adrenal gland. And I'm going to be taking hormones for life. And you're saying that the complication could be Cushing's syndrome? So you see where this is going. All right, so
Call the doctor.
well, it's just important that the patient understands what they're getting into. There's really no choice. Okay, they will die if they don't have the surgery. But at least, how do you reassure them? What can we do about adrenal syndrome?
We can correct it by paper.
It can be adjusted. Okay, it can be managed with the hormone dose adjustment. Okay. But this is just the reality. I mean, how do you suggest we manage it? And then the rest, of course, is related to, can this patient go into heart failure?
Yeah.
And SIADH and diabetes insipidus? So here are your management. I already mentioned them. The monitor blood pressure. This is for Cushing's disease still, okay? Cushing's disease, Cushing syndrome, meaning high salt sugar. Yeah. Yeah, it's it's one of the endocrine disorders. So here, fall precautions and handle them gently again. They are at risk for fractures. They can benefit from osteoporosis treatment. What are those drugs again? Biphosphonates. Again, what do we teach patients? How to take their biphosphonates?
Sit up.
Okay, empty stomach first thing in the morning, and they sit up for how long? Okay, up to 30 minutes. And they drink it with a full glass of water. Okay, 8 ounces. Protect them from infection, protect the skin. Body image, I mean, as much as you can. Okay, they can wear makeup. Okay, you can still look good. And you shave?
No.
Yeah,
Carefully.
why not? Okay, but they are also at risk for bleeding and skin injury. So we use what type of razor? Electric razor. And same thing, teach them about adrenal crisis. Okay, because they eventually get sick, get an infection. Yes, it's part of the consequence. You're taking hormones for life or steroids for life. You eventually get sick, and what do we teach them when they are sick and can no longer take the oral? Okay, we tell them what to do. Okay, if they can, if they're too sick to take their steroids. Okay, that's it. I have no more time for another topic.
Thank you.
Actually, I do.
Yeah.